everyone. We're going to have Dr. Catherine Page teaching us today about fetal alcohol spectrum disorders, which could be a very important topic to some of us to learn into detail of this. So we're really excited to have Catherine teach us more on this. So I'm going to go ahead and cover some of the basics, introduce ourselves before we get into the topic. My name is Bonnie Solis. I do have my bachelor's and master's in social work. I have experience as a clinician, currently serving individuals, learning about mental health, learning about anger, and different things that they could be dealing with day to day. And also have served with foster children, parenting classes, with the court system, hospital system, all things social work related. So really excited to learn about this along with you all on fetal alcohol spectrum disorder, as Catherine gives us an overview of all the great work that she's doing and teaches us about this. So let me go ahead and introduce Dr. Catherine Page. She has her PhD in clinical psychology, internship at Stanford Psychiatry Alcohol and Drug Treatment Center, research in hypnotherapy and political trauma. And this is something which she also does like a lot of volunteer work in. She's very involved with various collaborative aimed at better systems for youth and mental health, education, community behind all of this. For Catherine, she's also a restorative justice as a particular interest along with immigration reform and improving the well-being of the Latino migrant families. Catherine's mission in life is to raise awareness around resources in this topic that we're covering today, fetal alcohol, to the same level that all autism is at that awareness. We're aware of autism and the diagnosis is there, but we want to make sure that we're bringing awareness and educating others on fetal alcohol syndrome disorder to that level as well. So she has created and ran 2 FASD diagnostic clinics in county hospitals, which would be Santa Clara County and Laysan County over in California. She's now working with groups to bring California out of this stone age regarding this condition. So we're really excited to have her here. And she's really working on a lot of the training process here, ensuring that everyone is educated on this, especially with mental health providers, and providing this across state agencies. So we're excited to have this virtually access across the country in different states to bring more awareness on this important topic. So I'm going to go ahead and cover the reasons why this is important. So if I can have Dr. Page, go ahead and introduce yourself if you'd like to share what you're doing.
Sure, I am delighted to be here. Actually, I'm finished with the Los Angeles County training mental health workers, currently working with University of California, Davis, training social workers on this. Do you want me to just go straight into this slide? Why is this topic important? Because you already did such a thorough introduction.
Yeah, go ahead and share how you worked on this important topic. Go ahead.
Okay. This is, I should say, it's personal to me. It's my life mission really is to raise awareness to the point that fetal alcohol becomes a household word like autism, and people have a sense of what it is and how much of it is out there, and to look for it, to recognize it, and then treat people differently who it looks like probably have it. It's common. Most of us in the field are using the 5% prevalence number, which is 1 out of 20 people in this country, and in Europe, it turns out, even though they've had wine for, millennia in France and Italy, they still have the brain damage that comes from being exposed to alcohol during pregnancy. So we got there's a lot of us out there, and I have a version of the condition myself, which I may be sharing a little bit during this conversation. And it's for most of us, the central presentation is ADHD, which everybody kind of knows about at this point. But if you have ADHD with a bunch of other complicating other things like your balance is bad, your memory, your ability to plan, your uh, let's see, I'm leaving out a lot of things. I'm just giving you the thumbnail right now. If you've got ADHD with a lot of other um, mental health people call it comorbidities, but it's just other stuff going wrong than attention, focus, um, kind of thing. So that's what we have out there. And you will notice that I lose track of where I'm going if I get into a particularly long sentence, which I just did. So I think I was saying that it really is a personal mission for me to raise awareness of this. And I was throwing in some other information while we were at it about really ADHD is kind of your red flag. And then if you have mom drinking, um, then you can keep going in your detective work to figure out if this could be it. And most people, most clinicians, most probation officers and social workers who are aware of fetal alcohol um, do not have the diagnosis going along with the person they're thinking about. So pretty much everybody's in the same boat of, okay, this is a working hypothesis. We're going to go ahead as if we're going to put the principles of intervention and support in place. And we'll be talking about those later, I think. But that's where we mostly are in this country is without the diagnosis. But you, after this hour, it's my intention that you will have a little lens in your pocket that when you're dealing with somebody confusing, that's not responding to regular parenting or regular treatment, you pull that lens out and go, oh, could be fetal alcohol. Let's see if it's this, 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 this. So we're going to get to that in a bit. Um, so it is usually people that have fetal alcohol are diagnosed with ADHD. And then treatment, it doesn't really work so well because that's not the whole picture. Part of it can be medicated, part of it can be addressed through regular therapy. But if you know the whole raft of um, neurobehavioral issues, at least have an idea of what they could be, then you know what to look for. So that's why I am so happy to be speaking with you, is because you're going to come out of this having that little lens in your pocket that you can go, oh, okay, A, B, C, D, yeah, checking all the boxes here. So yes, you will understand. Maybe you already do, but by the time we're done, you're going to understand why fetal alcohol hits vulnerable populations disproportionately. Big part of the reason is that fetal alcohol makes them more vulnerable. Um, Wind up in trouble with the law. And in foster care, who has their kids removed? People that are not quite capable of adequate parenting. And a lot of times there's alcohol involved. So special ed for sure, and homelessness, the chronic homelessness, the people who are kind of in chronic trouble, not able to pull it together and do life. Um, and when we understand, or at least hypothetically, like I said, that this person that we're trying to help has these kinds of brain dysfunctions, then we can support them better. And I think there's one of our questions today has to do with how do we support them better? So, so we will get to that. So, fetal alcohol is preventable, um, hypothetically, right? And ideally, because we're never going to stop people from drinking. And you never know that you're pregnant right off the bat. And a lot can happen before you know that you're pregnant. Um, so we're never going to totally prevent it. But especially when it's identified early, so that you know that that the child's misbehavior and meltdowns and resistance and oppositionality and general pain in the butt behavior is not on purpose. They'd rather not always be in trouble. Um, and it can be, supports can be put in place. Sneak preview here, the biggest, the most effective intervention is understanding that it is not willful, it is brain wiring, brain damage. And that's a hard concept to really get, especially in the moment when your kid is swearing at you and throwing things. And it's hard to step back and take a deep breath and remember. We're talking brain damage here. I may be able to give you a little example of that later on. Raising awareness. It is the single most effective intervention. And here's my first dose of pressure on you, can seriously turn a life around. Because all this kid's world is going bad kid and bad parents. And you sit at your meeting, your team meeting, and you say, wait a minute, let me shine a little flashlight here. You feel that little pressure?
Yeah, thank you so much. And we'll get into this a little bit further. We really appreciate being able to understand the importance of all of this, of the numbers, how it affects, different populations that we could be serving in our practices or maybe have interest in, serving later on, um, as well as how it's preventable and how we can advocate in those meetings. So as we get started here, a little bit further into detail on some of these questions that we can have on these topics, could you start by giving us a really clear understanding of like what is this definition of fetal alcohol spectrum disorder and what this encompasses?
Okay. The first, um, the first thing that I want to say is that everybody that has fetal alcohol is different. There are some core neurobehavioral glitches, and I'll tell you those. But it's really important to remember that I heard somebody say this about autism, and it's maybe even more true about fetal alcohol, that if you've met somebody with FASD, you've met one person with FASD. Okay, so we are very different. The key issues, the key things okay, from the outside, what you might notice, the red flags are, and are we, Bonnie, are we talking, is our group that we're talking to here mostly dealing with adolescents, kids, adults, or everybody?
It could be any age,
Okay,
generally mental health professionals.
okay. In newborns, many people with fetal alcohol look totally normal. You don't recognize anything until they hit the age of reason, which is 3, about. And then at that point, you're expecting some things to kick in, like executive functioning, where you can actually learn from your mistakes and then not, you touch the hot stove, you get burned, and you don't do it again unless you have fetal alcohol. In which case it's, ooh, stove, let me try that. Ooh, stove. Ooh, ouch. Ooh, let me try that again. So you've got the core issues that show up in nearly everybody with fetal alcohol is that a difficulty connecting cause and effect, learning from mistakes, learning from, parenting techniques have to do with consequences, rewards, taking stuff away. That requires the brain to connect cause and effect. And people with fetal alcohol have a really hard time with that. It's like there's a little disconnect in that wire. And so that's one of the key signs is this is somebody who is just not learning from their mistakes or consequences or other parenting techniques that are based on that behavior management. You also have kids and adults operating at a much younger level than chronologically. Um, you'll hear other fetal alcohol teachers say, oh, they're operating at half their age. No, no, no. We're all different. But it is very common that those of us that have it operate younger. I will spare you some of the gory details of my own development and the ways that, that I had the judgment of a 13-year-old when I was 30. But take my word for it, it was there. So you've got a person, say, an adolescent who looks and talks like a normal their age, right? And yet the behavior, the choices, the reactions, the emotionality, the friends, the games, the movies are those of maybe a 7, 8, 9-year-old. And that's a key. If you see that coming down your hall, it's not just trauma. Trauma makes it worse and harder. Fetal alcohol makes trauma harder to heal. But if there's fetal alcohol, you've got executive functioning or learning, consequences. You've got the younger functioning. You've got a reactivity, a sort of meltdown when you're a kid, meltdowns. Uh, uh, um, of course, there's externalizers and internalizers. Externalizers being the kids that you can see that they're mad or upset. Internalizer being like a lot of us nice girls who, and we just get depressed and quiet and call ourselves bad names silently. Um, but the upsetability is still there. And if we had a ton of time, I could tell you some fun research that demonstrates that you can see this in infancy, the startle reflex. Um, but at infancy, you really don't see much unless you've got one of the, like, say 5% of people with fetal alcohol who have facial features. And that's called fetal alcohol syndrome. I know we're going to get to that later, but because contrary to what a lot of people think, that everybody with fetal alcohol, you can see it in their face. That's not true. If you can see these features, which we'll describe later, then you got your diagnosis. And then you start looking for these sort of neurological issues as they get older. The most common misdiagnosis, I think you probably already got that, is ADHD or bad kid or bad parent. You've also got, let's throw in oppositional defiant disorder, reactive attachment disorder, which is what I got with my son, even after, being raised in a calm and relatively sane household. I kept taking him for help, um, and kept getting slapped with reactive attachment disorder. You must have abused him, because that's what it looks like. It's one of the things it looks like. Um, Fetal alcohol doesn't go away across the lifespan. Um, for example, although I've learned to manage, kind of like you manage diabetes. I've learned to manage a lot of the features, the neurobehavioral features, but it doesn't change the fact that my memory is just toast. My, and that's never going to improve. My planning is bad. Things I get, triggered easily. But knowing that that's all part of this package is very helpful. So we're going to jump down to number 3 here on the slide for just a second and really make the plea that in addition to you advocating for all of this, the ideal outcome is that the client themselves become a self-advocate, that they understand their brain functioning, that they can manage the glitches. That's ideal. And if you've had a lot of trauma and if there's a lot of brain damage, that may not be possible much, but good to shoot for.
Yes, we learned a lot in this hour. And we'll see if we can get some of those questions. So if you're watching on YouTube, of course, pop some of those questions in the comments. If you're watching on our program, go ahead and send us an email so we can go ahead and hear from you and get some more information on this topic as we finish up here.
I
But
would love to hear, like I said before, I would love to hear your questions and comments and reflections.
yeah, thank you. We'll go ahead and share those once we wrap up and get to hear from everyone.
Okay.
But I see that you were sharing on some of the things that happen maybe day to day from this individual. So what would we see or hear in our offices as far as the challenges that this spectrum presents day to day?
Can you narrow down the frame just a little bit? If we're talking about community mental health, um, or let's pick, kids in foster care or behavior management problems, or just narrow it down a tiny bit for me.
Yeah, I think we can maybe, how can we advocate in the school system if we're seeing this day
Okay,
to
that's a whole different question. Um,
day?
Let me try and take the first one, even though it's kind of broad. Um, if you've got somebody coming into your office um, with behavior, and I imagine that behavior issues are what bring a kid into the office more than anything else. You know what to do about depression, you kind of know what to do about anxiety. So let's say it's behavior. Um, Meltdowns, upset over little things, you're going to see, and the meltdowns and upset can be very intense and very negative and physical. You're going to see behavior and reasoning that is younger. You're going to see somebody that may talk well, but doesn't, if you pay attention, and I know you do, that doesn't listen well because the connections are not, connecting. They, so in a back and forth conversation, you might get responses that are completely, off, or the kid can get mad or stomp out or throw something or whatever. But oftentimes that's because auditory processing isn't working. Um, Speaking tends to work really well. We can be good talkers, but terrible listeners. Other things you will notice is that whole world of ADHD, oftentimes with the hyperactivity, but not always. So you get the distractibility, the tangential talk. There's also little strings of sort of autism-like issues woven in there. So you could get Asperger's-ish, hyper focus on one subject or another. Little social cue reading, and a lot of anger. And what you will also see is the parents of this kiddo are exhausted. They are being told what to do by friends and family and doctors and everybody, and nobody understands. Everybody thinks they must be doing something wrong. And so the parents are exhausted. They feel isolated. They feel helpless. Um, so that's a key hallmark. Marriages break up over fetal alcohol. How do we do for key signs, symptoms, and common misdiagnoses? We done with that one?
Yeah, we
Or
could touch on that one just a little bit, because I know you touched on it, but if we can go into more detail as to why this is often underdiagnosed or misdiagnosed.
yeah, um, it's almost never diagnosed. It's except in Canada. And Canada happened because the prime minister, about 3 prime ministers ago, had a couple of kids, adopted kids who were wonky, and somebody suggested he take them down to the Seattle clinic at University of Washington, and he did, and they both had fetal alcohol, and everything made sense to him then, and so he made fetal alcohol public health priority #1 for the following year. And we haven't had that luck yet. Um, so it's not diagnosed for a number of reasons. One is that people with fetal alcohol look totally normal and sound totally normal, but just like, you know, on purpose, problem solving or problem causing people. And that includes adults. If you're dealing with the whole family, keep an eye open for adults who have these features as well. So you've got the red flags for adults they're gonna look a little different because they're trying to manage an adult life. So a life of crisis, always chaos, always running out of gas, always showing up late, never having enough money, nutrition bad, all kinds of health issues, diabetes, because nutrition isn't thought through very well, um, not enough money oftentimes to, anyway, it's a whole package of what I think you would recognize. But again, you've got that operating younger thing. So you could have a 35-year-old adult who's actually, you pay attention and you notice that their decisions and their reactivity and their preferences and their rationale are those of like a 12-year-old at best. Um, and they're interrupting you, and they're fidgety, and they forget to bring their papers, and plus there is also in this package an issue distinguishing truth from fiction. So we've got a lot of what the field doesn't want to call lying, but is. We called it confabulation. Call it confabulation because that's what you call somebody with brain damage like Alzheimer's or a TBI. It's confabulation where you make stuff up. So there's some of the of what you will see in your office, whether the adult or the kiddo. And child beginning around the age of 3, the little ones are just not catching on. They're getting kicked out of preschool because they can be aggressive. They don't follow the rules. They're always, not doing what they're supposed to do. And the preschool teacher is trying to use their regular techniques to help manage that behavior, and it's not working. So those are some of the things that you will see, and it gets misdiagnosed because we all look so darn normal. We talk normally. We don't listen normally, but we talk, we look, we dress for the most part totally normally. And this condition can be so easily labeled ADHD that and most people are not trained to diagnose fetal alcohol. So that's why it gets misdiagnosed and stays misdiagnosed. But the treatments They misfire.
Yeah. Thank you for sharing that. So as far as us as clinicians, as social workers, mental health professionals, what do we need to understand most urgently about FASD within our practice?
Gosh, I think that can boil down to just a few main key principles. One, how much of it is out there. And a, a couple more statistics that just add to the picture of there's a lot of it out there. 1 out of 20 of the general population. Um, 1 out of, like, say, 2 to 4 in foster care, and half of adopted kids. Kids involved with the juvenile justice system, about a third. Um, Parents who are having their kids removed, roughly half of them came through foster care, it looks like. And if you do that math, half of foster kids have fetal alcohol, so a quarter of the adults that you're meeting through CPS um, have fetal alcohol. So key point number one, just how much of it is out there. Key point number two, looks totally normal, but the person is problematic, is going to make people mad, disappointed, irritated, frustrated, all over the place. So if somebody walks in with that, I don't know if anybody remembers good old Pigpen from Charlie Brown, that comic strip with all the flies and dust all around his head. Well, think of that as kind of behavior, chaotic behavior. Somebody walks in with that chaotic behavior cloud around them. Um, that is when you start to inquire of yourself and whoever else you can about whether there was alcohol. And one way to do that is you don't need to be real specific. You can ask whoever is available, was there alcohol in this person's household when they were little? Oh, yeah. Was it everybody pretty much? Uh-huh. That's all you need. Nobody that I've ever heard of has, unless they just aren't drinkers, stops drinking before they get pregnant. Lots of us stop drinking when we know we're pregnant, but damage can be done. So, key, um, what did I say? How much of it is out there, how normal it looks. If you got a diagnosis of ADHD and this kind of chaotic life and behavior, start to think about fetal alcohol and start the inquiry. And remember, the younger functioning, and what that's going to do for you, hopefully, is it's going to help you bring your expectations down to that age equivalent. So think of somebody that you worked with that you think kind of fits this picture, and imagine what their functional age might be. And I bet you can. And no, this is not hard science, of course, and totally subjective, but you can do it. And if you can keep that front and center, then you're not going to be asking complicated questions. You're not going to be asking, for an insightful exploration of motivations when you've got somebody that's 16 in front of you, but's actually 8. So that's a big one to keep in mind. Also really important is, and I know you do this anyway most of the time, but extra important here is finding the strengths, what makes a person calm and organized and happy, and use that in your work. If somebody is, a mover, you play catch with the Nerf ball while you are talking. or you walk while you're talking. If somebody is only calmed by the presence of animals, you do your darndest to find yourself a therapy dog to put in that office. These things are kind of primal, they're kind of primitive. They go to the nervous system. They don't have to do with insight or trauma narrative or, um, repairing the attachment issues or going back to the old days of therapy school, unconscious conflict. I don't know if you guys ever study that anymore, but it doesn't have to do with that sophisticated stuff. It is primal nervous system. Another thing is to kind of keep in mind is the sensory issues. Again, this is one of those strands that you recognize from autism. Sensory issues, sensory integration disorder. You got somebody that's playing with the back of their shirt all the time, or always fiddling with, their a wristband. Your little detective goes into gear and goes, oh, could this be sensory issues related to fetal alcohol? And you ask, do the tags on the back of your shirts bug you? Oh, yeah. And then you ask about, do bright lights bug you? What about loud noises? Um, you're graciously, in my hopes here, taking on the task of figuring out if this looks like fetal alcohol. Because if you get to kind of a tipping point, then you're going to start using the supports and the principles that apply, including keeping your expectations down to where you think the age equivalent is, and helping out with sensory issues. Like if the lights are too bright, you let them wear sunglasses or their hoodie, or you turn them down, or again, not sophisticated, go to the nervous system. And what you get then is you're maximizing the chances for healing and growth, which is what you're really there for. Maximizing the chances that this person's true self, true gifts, true self has a chance to emerge out of all of that anger and chaos and confusion and bad self-image, and you are kind of nurturing, watering, putting sunshine on this true self.
That was really great because we got to see how we're definitely encountering these individuals without realizing it, as you
Yeah,
mentioned, especially maybe within that CPS system or
yeah,
the family unit, especially some of us who are doing home visits within that environment, stepping into the client's environment.
yeah.
So for that, we also got to name some of those signs and red flags that we see as well, or that you've been able to observe for us to look out for. So thank you for that. Um,
Yeah,
how
yeah.
how
Well,
can
can
we?
I just ask you,
Yeah.
you've done home visits, yeah, and
Yes.
you've gone into places where you're going, oh my God, how can they live like this, right? Where there's just stuff all over and it's dirty, and it's really hard to get past the first reaction of, ew. What did I want to ask you about that? I'm not even exactly sure, but I wonder how, now this is a huge question. You may not even want to answer it, but how do you conceptualize that? You know what I
Yeah.
mean?
Yeah, I think there's different things to always consider. Again, we've talked about like the population, what they have access to, and my experience with this was very early on in my career. But a lot of the things that I also considered was we tend to have lots of stress in our life, right? And a lot of the times it's, well, how are we going to cope with the stress? Sometimes it's positive coping skills and sometimes it's negative, right? And those negative things are alcohol, drugs, and different things. Sometimes it's just the norm of what we're exposed to. So I had always considered it in some of those ways of a negative coping skill of, is there financial stress? Is there stress of caring for the child, not having a job or something stable for them, just different things, and that being a negative coping skill or the normal environment that they were surrounded by. And that's something
Yeah.
definitely to consider, but also consider around, is mom, is dad, dealing with this as, maybe something that they're not diagnosed with, and now, baby child that we see as our clients, also now dealing with this, and it being a generational thing,
Yeah.
as you're sharing.
Right. Right. In an ideal world, the intervention for an environment like the one that we're both seeing in our mind's eye is you get help. You get a house cleaner, you get somebody to help pick up every day, every couple of days, because for most of us who are dealing with fetal alcohol, um, it's really hard to do that level of cleaning and organizing. And that level of chaos in the environment further disorganizes and upsets us. So I've been really lucky with, if having some luck. And but boy, even when I didn't have any spare income, having a house cleaner was a necessity for me. And that was the only way that I could keep myself, organized enough. So, once again, a response, an intervention, we mental health and social worker types, we tend to think of empathy and insight and advice and maybe providing some tools like here's a chart, here's a day runner. Now don't forget to use it. Within an hour it's lost. Um, we don't have the system which would give everybody IHSS, anyway, household help to deal with this kind of thing. And that, like I said, that level, primitive level, is where a lot of the most helpful stuff can come in.
Yeah, definitely. And so in that, like having that support system, if we're not able to get that, but having that support system to help us out and alleviate some of that stress, whether it's in our environment or in other ways, right?
Yeah.
So with that, I'd like to jump on to that next question, right? How can systems of care be designated or designed, right, to better support this population as an individual or as a family?
I'm thinking of Los Angeles County, which is uh, uh, the county, as far as I know, that's the farthest ahead in creating a system of care. And it's only available for kids in the foster system. Um, and it's incomplete, but it's good. They do have diagnostic capacity that works fairly quickly. And then they have a system of a parenting classes specifically designed for fetal alcohol. So regular parenting classes are not helpful, I should say, and emphasize and may say again, because they are based on consequences. How you shape behavior is consequences. First, you build the positive attachment. That's great. But if your kid is still swearing at you and throwing chairs at you and punching holes in the wall, your ability to keep your own calm is, you're starting to think, I must be doing something wrong here. Um, so the system of care that has a parenting class that's not based on neurotypical functioning, but is based on this set of brain glitches that require a different approach for parenting. Really important. This clinic also has an occupational therapist, an OT, and that really is the cornerstone of mental health, if you think about it, especially for little tiny kids. Because if you've got a sensory integration disorder, everything is upsetting you, everything is a little painful. Your ability to control your reactions and your body is poor. And so an OT comes in and helps you out with all that and helps the household make adjustments to support that. So they've got an OT, they've got support groups for the kids as well as the parents. And then for the more complex cases, they have this really great program developed in the University of Washington called Families Moving Forward, which is spreading. So anybody that wants to sort of, lobby your supervisor to bring Families Moving Forward, you just Google it, you'll find it. It's specifically trains therapists to help out with families in crisis intervention, but mostly what it is support and education of the family. Like, how is this brain damage showing up in your kid, and what are the things that we can put in place that you can get ahead of it, that keeps the environment calm, that keeps the communication clear and calm and short, that keeps the education system as an ally rather than a hated enemy. Um, so you've got this Families Moving Forward intervention therapy program that really comes in close to the family and helps make that switch so that kids do move into self-advocacy. They are helped to find what are the recreational activities that are healthy, that make them happy, that are, good. Because, even though I, I should have this as a crawl across my forehead, if we don't identify brain damage of the fetal alcohol kind and we go on, oh, it's just trauma, or it's just ADHD, or it's bad parenting, or it's, bad kid, or it's blah, 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 the chances are good that person is going to spiral right down the drain. Homeless, incarceration, um, substance use disorders, crime, petty, nonviolent, very often, um, sink. If, however, we do, and this is my second dose of pressure to you listening, if we do shine that flashlight sufficiently and go, wait a minute, this looks like it could be wirings in the brain damage. Um, and here's what we can do to create an environment that helps maximize their chances that they're going to learn, relate in a healthy way, learn to self-advocate, um, have fun in life. You've got a pretty good chance of having a good life. So they're in Los Angeles County. They're really lucky. They're really, really lucky. I'm working on Santa Clara County, California to get to something like that. But it really happens one person at a time. And those of you that are here, you could be that one person in your agency, in your town, in your church, in your Girl Scout troop who goes, we need to understand this stuff. We need to recognize it. And so really what the system, from first kind of having the, gosh, this could be it, to achieving formal diagnosis, to putting those interventions in place, to changing the household, to supporting the parents, it really all begins with kind of the awareness of it's out here, this is what it looks like. We are operating without the diagnosis, but that's okay. We're going to, look up some more information on it. We're going to see some videos. We're going to learn more, and we're going to educate our peers. And that right there, understanding even just a hypothetical working hypothesis is going to be enough to turn this person's life around. And a whole subset, like all the kids in probation, if you out there, one of you, you're in probation, you're working with probation, share this information, please. um, it's That's what systems of care can do. And of course, it gets more and more formal and institutionalized in a place like LA County that has woken up. And they, I think, I don't know if we said this, but a few years ago, the Board of Supervisors put out an order that said all the relevant departments have to be trained and have to make changes. And that's why I got to train all of their mental health people, 10,000 of them. 60 trainings, which was just so fun. Um, but so you there, as part of a system of care, can light that little light that might clear up a murky corner for one client. But you're going to share this information. So um, systems of care have a long way to go, even in LA. For example, putting fetal alcohol as the primary diagnosis in the billing system still isn't working. So they have to put ADHD or whatever shows up in that primary box. But they always put the fetal alcohol information. Fetal alcohol is the secondary diagnosis. It is in the DSM, the latest DSM. It is in the third section, but it's moving rather quickly into common usage. And I'll just tell you, it's got a new name. Um, it is also a mouthful. NDPAE, neurobehavioral disorder associated with prenatal alcohol exposure. NDPAE. ND-PAE. Look it up. You'll find it in the DSM. And the beauty about this is that a system of care everybody used to think, we have to do this diagnosis with a whole table full of very expensive professionals doing a lot of testing. OT, speech, school psych, physician, others. And that costs $5,000-$7,000. It takes years on the waiting list. It's not necessary. There's no other diagnosis, there's no other disability that has to have that gold standard. None. And look how ADHD is diagnosed. 15 minutes with the doc and their little checklist, and you got it. Fetal alcohol, nobody wants it to be quite that instant. But in that new NDPAE schema, it's very clearly encouraging people who are currently in a position to diagnose ADHD, for example, which is a neurodevelopmental disorder. It's not really considered mental health, even though it's in DSM. Encouraging people who are already diagnosing ADHD, for example, to find out a little more about fetal alcohol and just diagnose the heck out of your clients who you're pretty sure have it, and you're following the diagnostic criteria, which consist of the following: alcohol exposure more than minimal. Talk about that a little more in a second. Impairments in 3 areas. Self-regulation. That can be attentional issues like ADHD. It can be rage blowups. 3 areas: self-regulation, adaptive behavior, right? Kid is operating much younger, social skills issues, not getting with the program in whatever circumstance. And the third one is neurocognitive, or your thinking. How's your memory? How's your ability to do logic? How's your, planning ahead? Um, Cause and effect. The impairment in those three areas, it's no secret. If you've got impairment in those three areas, there's evidence all over the place, and the drinking, and no better medical reason. So, didn't get hit over the head with a baseball bat, didn't have a 105-degree temperature, didn't have, hypoxia at birth. You got it.
Thank you for sharing that. I know you mentioned that minimal consumption of alcohol. So could you share a little bit more of that? How could we look into?
Yeah. Yeah. Well, it's defined in the DSM as more than 13 drinks a month or more than 2 drinks per sitting. Now, this was very contentious, and they argued about it for months and months before they finally, could all agree, the committee, because some people are saying, are you saying that that level of alcohol or less doesn't cause any damage? Because that's what it looks like you're saying. And that's not the case. What happened was this was a number that everybody could live with. The truth is, and it's unfortunate, there is no dose response. There is no way to predict how much alcohol is going to cause how much damage in any given person. You've got statistically, the more binging goes on, and a binge is 4 drinks in a sitting. So a lot of us who drink, and we're going to a party that lasts 5 hours, we have a binge. So that's statistically what causes the most damage, the high blood alcohol level. And it only takes once. But there's also evidence for, and this is thanks to lab mice who cannot lie about how much they drank the night before. Um, they there are some that come out with some damage of the same kind of pattern from minimal drinking. And newer research is, and I can't quote where, I just heard this at a training a couple of days ago, says that even if you're exposed to any amount of alcohol, there will be some effect. It might not be measurable, it might not show up in your performance anywhere, but something's getting affected, even down to a very subtle level. So that's the story about alcohol.
Yeah, thank you for that, because it's important for us to consider, especially in our assessment questions. Some of us may already know to ask us very specific questions of, well, how many bottles or cans? And when we ask that question, being very mindful of, someone can say, well, 1 or 2 cans, but it was those really big cans. So really considering the amount of ounces, and depending on the age of your client, and as you're mentioning too, of where they see themselves, can they really determine that amount? If we're asking some of those questions as a family. So thank you for that.
Yeah.
Would you like to share a little bit more on some of this personal experience as an adoptive mom of an individual with FASD? What advice would you give to caregivers raising a child on the spectrum?
Well, first of all, remember you're probably not going to know. Even, if you have adopted or you are fostering this child, chances are good that you don't have the information that A, there was alcohol, B, there is a condition, diagnosed condition there. So the first advice that I would have is pay attention to these things that we've already talked about, like, is this kiddo operating younger? Not learning from mistakes or consequences. Looks like disobedience, looks like chronic disobedience, but even where it would benefit them, something that they really like, if they keep not connecting the dots, keep that in mind. put together your little picture of, okay, do we have youngness? Do we have cause and effect not working? Do we maybe have sensory issues going on? Is this a real picky eater? Is there a lot of upset when we go to Costco at Christmas time because there's too much incoming stimuli? Is this somebody, oh, I forgot to mention sleep disorder, which is really common. Is this somebody with also common vision and hearing problems? It's even the ears are part of the midline as the fetus is developing, and this is really a midline issue. Is this somebody that really lies like a rug and in crazy ways where the evidence is all around? And without, necessarily being malicious or manipulative about it, it just happens. So start to connect these dots, these pieces of the puzzle. What might be going on with this child? Does it seem like it is neurological rather than learned or trauma related? And if you take this child to a therapist, make sure that if there is a chance, a reasonable chance that there was alcohol involved, like foster care or adopted. You go to therapy, you make sure that clinician is fetal alcohol informed. And if they're not, ask them if they're willing to become that way. So, as a parent, put the pieces of the puzzle together. And I'm also going to send Bonnie a resource list for families, which has some great little videos, a couple of books, some articles, some really helpful hints on how to really do right by this child and how to keep yourself out of that anger zone, which is the logical one for us to be in with much of this behavior. So, also definitely we're back to our learning objective number 3 here: advocate for appropriate, etc. Definitely, if you're seeing this pattern or if you're seeing this child struggling in school, period, advocate for an IEP in school. Advocate for special ed services. If this is a child that has trouble with self-regulation or co-regulation, you're doing your best, you're staying calm. Child is out there melting down all over the place. So co-regulation is not working. OT, look for an occupational therapist. If you're in the foster system or post-adoption, you may have access to some funding for that. Even if you don't, I am hoping that you will understand the benefit of digging deep into your own pocket and getting some OT help. Find yourself a support group. There are some lovely online support groups, and they're listed on that resource list that I will send. Because if you're not part of a group that understands what you're going through, you're going to feel really like pulling out your hair, isolated, like I said before, and tired. Meds help. I've worked with lots of families who are opposed to medication on principle, and the rest of their kids are healthy and happy and, not eating red dye number 2 and not sugar, and they're doing great. Now this kiddo gets adopted or fostered in the family, and they are not doing great. And meds can, and they're the same meds that get described for any of these partially true diagnoses like ADHD, like bipolar disorder. I forgot to mention that. You got your mood swings. For rage, you got medications that address all those symptoms. You are not going to medicate away fetal alcohol spectrum disorder, the wonky thinking, but meds please consider them if your household is in chaos. Let's see. I think that does it on parents.
Yeah, and it's something to look out for ourselves as parents if that's something that we're being like exposed to or see that in our own environment, but also having that empathy for our clients and the parents that we're serving as well. So thank you for that.
Yeah.
And I know you've mentioned systems like the corrections, education, welfare. Why do you think it is that the condition remains invisible within these spaces?
Well, a lot of it has to do with how different we all are. We do, with kids who have autism and adults who have autism, you're it doesn't take long before you're going, something is a little off about this person. Something's different. With fetal alcohol, we don't have that. Most of us look totally normal. 95% of us do. Um, we talk normally. Most of us, and this is also on a spectrum, manage to live our lives like regular people, but keep getting in trouble, keep failing, keep losing jobs, keep losing relationships, keep getting into money trouble, legal trouble, dropping out of school, etc. And it just looks like uh, irresponsibility, lack of motivation, fear of success, you name it. Um, we have many ways to describe and name this condition that are not the accurate one. So it slides under the radar for that reason, but another main reason is that professionals avoid the subject. When you're talking to the birthing parent, I have not gotten used to saying that yet. I still say mom, so forgive me. Give me the old person forgiveness here. Um, OBGYNs have talked about how they do not want to really bring it up because they don't want to break the rapport that they have with somebody. Um, they don't know, and then pediatricians don't want to bring it up because they still have this old idea that there is nothing to be done anyway, so why label the mom and kid? Because you are labeling the mom, the bio mom.
Yeah, most definitely.
Yeah, so there is stigma that is huge. It is just huge. And we also, as a field, we have not done a good job in creating the kind of safety for bio moms of kids with fetal alcohol damage that we have created for addicts in general. 20 years ago, 25 years ago, it didn't used to be okay to say I'm an addict. Now it is. It's understood. It's a biological thing, not a moral failing. So we've done a bad job at creating those spaces of safety. I
Thank
don't
you
know
for
if
that.
that answered your question.
Yeah,
Did
most definitely. Because it is important for us to understand those aspects as well, especially as we were first touching on this topic. Sometimes as a mom or someone who is becomes pregnant, it comes later on, right? Most times, right? And so it's really hard to kind of change that behavior without knowing prior to. And if it was a habit or behavior, maybe a stressor that's involved of kind of changing that habit even after, right? It's, as you mentioned, it's not something where we just kind of change.
right,
So thank you for
right. You know,
and
I'm just going to double back and say what might be a little repetitious, but you ask such a good question about why does this, given that there's so much of it out there, and there really is a ton of research, and given all that, why does it keep getting missed? And I think really another big piece is that the behavior, the reactivity, the upset, all of that just causes the system to go, bad. Here's some more punishment. Maybe you'll learn now. You have to learn from your mistakes. You have to get responsible. And every time it doesn't work, it's like you get slammed with the word, okay, you're seen as a worse person. And pretty soon you are chronically incarcerated or homeless.
Yeah, thank you for sharing that because it is important for us to understand maybe with that challenging client. I usually find it to be like more motivating. Like we need to figure this out. There's something, right, that we need to figure out to help the client adapt to their environment and adapt to different things so they can, do day-to-day things of having a job and or going to school depending on their age. So thank you for mentioning that. And just to wrap things up on this, we have one last question here.
Can I interrupt you?
Yeah, go ahead.
I'm sorry. Because you were just putting it in terms of helping the client adapt to, do things better. But really, all of the intervention around fetal alcohol, all of the research and experience is the client's not going to change. We have to help the client's world change. The people that are supporting this person, the people that are having to deal with them, um, they have to change. That's what really all the intervention does.
Yeah,
Yeah.
thank you for mentioning that. It's
Yeah.
important for us to keep that in mind with our clients. Thank you. So here
So you were saying,
we have one last question here. If we could wave a magic wand and
oh,
change one thing about how society handles FASD, what would that be, and or what could you name?
well, really, it would be a lot like how Canada is doing it. And even people in Canada say it's nowhere near as much as it should be, but it is a household word in Canada. There is there is awareness of what happens. If you drink, if you're pregnant, you could have a kid with ADHD and plus a bunch of other stuff. It goes way beyond what it is here, which is, yeah, you might hurt your kid. In what way? Oh, they could be born addicted. It's just like Canada's doing it lots. I think it might even be in school curricula. They have every social worker, every mental health person gets training in this stuff. It's the level of, it's like the rising tide floats all boats, right? It's like the level of awareness and competence in Canada is just up to here, where in this country it's like a lot lower. So that.
Yeah, thank you, Dr. Page, because that's something that you're doing here, and just trying to get that word out there. So thank you for all that you've done in California and joining us today to get that word out even further on awareness on this topic. So we just want to thank you so much for all of the great information that you provided for us today. And of course, we'll have if any of you all have questions, or would like to share anything, if you're watching on YouTube, go ahead and drop those in the comments. And if you're watching it on our program, please shoot us an email so that we can get connected with Dr. Page and get those questions answered and back to her. She'd like to hear from you.
And I will send you those couple of things that I promised.
Yes, so we will have some of those tools and files that Dr. Page mentioned of access on our program so that you can access the tools and pages that she will be providing to us. Thank
Great.
you so much.
Thank you so much, Bonnie.
I hope you enjoyed this continuing education course from Agents of Change. Want to earn your CE credits for this course? Visit agentsofchangetraining.com or the link in the description to purchase the course and take the post-test. If you're looking for more CEs, check out our unlimited plan. You will get unlimited access to 150 plus ASWB and NBCC approved continuing education courses for one low annual fee. We're always adding new courses. Did I mention we also have 5 free CE credits available too? Check it out at agentsofchangetraining.com.